This is Module 3 of the educational program Promoting Successful Rehabilitation Outcomes in Multiple Sclerosis. In this module, we will discuss evaluation and treatment of balance dysfunction in MS. Let's first talk about what is balance. Certainly, as we can see by this young individual balancing on a skateboard, it's even distribution of weight enabling a person to remain upright and steady. In rehabilitation, it's the ability to perform activities of daily living and functional mobility without the loss of posture or position. The physiologic components of normal balance include adequate strength and postural control, which should always be evaluated first. Then the specific systems of balance, which include visual, vestibular, and somatosensory processing. We need an integration and processing of equilibrium reactions, righting reactions, and upright postural control integrated with visual, vestibular, and somatosensory processing to enable the patient to have appropriate balance for all of their activities. Balance dysfunction in MS is most often the result of demyelination throughout the central nervous system, which can impact balance, coordination, strength, and sensation. When we have this demyelination, we can obviously see in our patient an increased risk of falls. As stated previously, the anatomic components of balance include the vestibular system, that is the labyrinth of the inner ear, which gives our brain an awareness of spatial orientation and posture. We also have the visual system, not only what we see, but our ability to move our eyes. And how we move our eyes is integrated with the vestibular system's processing of where our head is in space. Proprioception and kinesthesia information is also transmitted to the cerebrum and cerebellum, and when these tracts are demyelinated, that can result in abnormal processing of where our feet are in space. Impairments in MS that contribute to balance dysfunction include the weakness in the lower extremity, spasticity in the lower extremity, the presence of ataxia or lack of coordination, weak control of the trunk, and then those specific balance deficits such as sensation, visual deficits, and the vestibular disorder. It will be important when examining a patient with multiple sclerosis who you suspect has a balance dysfunction to first examine for the presence of weakness and spasticity. If we don't treat those particular impairments first, our ability to improve the patient's balance overall may not be successful. That trunk control or core stabilization becomes another factor to examine in the patient very early on. Then we should focus our attention to somatosensation, visual deficits, including the optic neuritis, but also ocular motility, and then vestibular disorder, which we will now describe in the remaining slides. So comprehensive balance examination in a person with MS, first start with that musculoskeletal examination. Does the patient have adequate range of motion and strength to hold themselves up against the forces of gravity trying to push the body forward? Is somatosensation intact, the awareness of where not only the head is in space, but where our feet are as we're moving? The visual processing, not only what we see, but the ability to move the eyes. Vestibular ocular, which can often become a symptom in patients with multiple sclerosis, where what the eyes are seeing and moving doesn't match up with what the inner ear is saying. And then certainly in multiple sclerosis, we can also have vestibular deficits. Our next patient has an EDSS of 4.0, and to look at his gait, we don't really see any specific challenge to his ability to ambulate. However, now we'll ask the patient as he's walking to move his head left to right to scan the environment. And as he does that, he starts to have a little bit wider base of support and a little bit of a stagger to his gait. We'll see that demonstrated even more so on his return walk. This is a perfect example of a patient with multiple sclerosis that has a condition called internuclear ophthalmoplegia. It's a lesion that occurs in the medial longitudinal fasciculus, causing demyelination. See that loss of balance there? Demyelination of pathways that connect the vestibular and ocular system. So let's look at his eyes.
He's performing saccades, repeatedly moving the eyes left and right, and you'll see the asymmetry of the eyes, meaning that the eyes do not move together. The slowness is actually in the adduction of the eye, and unfortunately for this gentleman, he has a bilateral INO, meaning both eyes are involved. We'll revisit this during the examination component of balance. Here's Andy, EDSS of 6.0, and we have a balance problem here with Andy, but his balance problem is more related to the problem we've previously discussed, that being weakness and spasticity. He has excessively abnormal gait deviations with the cane, but he's safe and independent with the cane. When we take the device away, we see even greater challenge to advancing that left leg forward and resulting in loss of balance. So balance now, the cause, weakness and spasticity. And here we are back with Jean. Recall that she has difficulty transferring from the wheelchair to the mat. She's an EDSS of 8. She's not ambulatory. Here she is maintaining a static sitting position. And static sit, she's okay. She can put her hands on her lap and maintain an upright sitting position. The problem for Jean with balance comes more into dynamic sitting. So when the therapist is starting to challenge her to reach left and right across midline, we see that the problem is trunk instability or weakness. Deb has an EDSS of 6.5 because she's using a bilateral assistive device, the four-wheeled rollating walker, but with that walker, her gait really looks very good. If we take the walker away, which we should do at times as long as we keep the patient safe, we see the problems with her balance. Wide base of support, staggering, no arm swing, no head motion, very hesitant gait pattern, wanting to grab that handrail. So with the bilateral device, she does score a 6.5, but she's safe and independent. Ambulating without an assisted device puts her certainly at greater risk of falls. Now we'll do the examination of balance with Deb, and the first thing we do want to clear is the musculoskeletal system. Active range of motion of the upper extremities was within normal limits. Manual muscle testing of the upper extremities is going to be within normal limits. But the key with balance, of course, is the strength and flexibility of those lower extremities. Active range of motion of hip flexion is just fine, very different from what we saw on Andy. Can take resistance to iliopsoas. Quadriceps activation, no problem. Can take resistance to knee extension. Can also take resistance to hamstrings, going through knee extension and flexion, no problem there. Dorsiflexion, not difficult. Can take resistance to dorsiflexion, activating the anterior tib and the gastroc soleus. And Deb's manual muscle test grade overall is 4 to 5 out of 5. We'll now ask Deb to move supine because we also want to check for the presence of spasticity. Recall, musculoskeletal is the first line we're going to address if that's a factor in balance. So the therapist now is doing a straight leg raise, going to move the leg quickly into knee flexion and extension, checking for spasticity in the quads and hamstrings. Now checking soleus and then gastroc. No resistance there at all to the quick stretch performed by the therapist. Adductors are also intact, no presence of spasticity. Same test now on the right leg, checking the quads, no resistance, hams, no resistance. Going back down to the ankles, soleus, maybe a slight catch there, a 1 in the soleus, maybe a slight catch there, a 1 in the gastroc, but certainly didn't impact her gait pattern at all when she was using the four-wheeled rollating walker. Adductor muscle was cleared, no difficulty. In balance, recall that we also need to assess sensation. So the therapist will now test proprioception in the patient. So she'll position the one leg, patient's eyes are closed, ask the patient to match it to see if she has proprioceptive awareness of where her extremities are in space. And certainly you can see that Deb is able to match up with every position change, recognizing where the joints and muscles are. No difficulty there with sensation as assessed by proprioception. Now we'll move into that ocular motor assessment. So we're first performing smooth pursuits. The therapist moves a target, in this case we're just using a marker, and we're watching the patient's ability for their eyes to follow that yellow top of the marker. Are the eyes moving symmetrically, equally? Is there any presence of nystagmus, that extra beating of the eyes? Typically we move the marker through an H position. That allows you to test all of the planes, diagonal planes of eye movements that are possible. I'm going to draw your attention to that left eye because we're going to see that that is going to become difficult. Here's convergence. The target is coming close to her nose. Look at the difficulty with her adduction of that left eye. See how the right eye nicely adducts? The therapist is pulling the target back, then back in again. She doesn't have as much adduction on the left eye. That would be medial rectus. That would result in an internuclear ophthalmoplegia, which we saw before with our gentleman. So here we are, saccades, and there is the deficit. So the right eye moves, abduction, adduction. The left eye, adduction, cannot move at the same symmetry as the right eye. We also perform vestibular ocular reflex. The eyes are now stabilized on the target, rhythmically moving the head side to side 2 hertz per second. Do it in a horizontal plane, and then do it as well through a vertical plane. The key here is looking for loss of fixation, the patient's inability to maintain their eyes fixated on the target.
Standardized measures that can be used in balance dysfunction include the Berg Balance Scale, the Timed Up and Go, and the Dynamic Gait Index. For the most part, the Berg Balance Scale has become the uniform standardized measure to look at balance in all populations, including stroke, community dwelling, elders, patients with vestibular dysfunction, and patients who are at fall risk. The Timed Up and Go has been utilized extensively in identifying patients at fall risk, and the Dynamic Gait Index has been utilized in patients with vestibular dysfunction and has been demonstrated to be an effective tool in patients with multiple sclerosis.
We'll now see Mike display the Dynamic Gait Index. The first item is walking along a level surface. Because he's using the straight cane, he automatically would be scored a 2, the highest score being a 3. On his return walk, we'll now ask him to demonstrate a change in gait speed. So first normal pace, then as quickly as he can, and then as slowly as he can. And we're looking for any problem with challenge to balance, stagger, risk of falling. The third item is horizontal head turns. So he's ambulating. The therapist will cue him to look to his left, then look to his right, then look straight ahead. And she's observing again for any challenge to his balance as he's turning his head left and right. If he had an I and O, that would have been more challenging for him. The next item 4 is vertical head and eye turns, looks up to the ceiling, then downs to the floor, therapist observing for any challenge to his balance. The fifth item on the Dynamic Gait Index is the gait and pivot turn. So the patient will ambulate 10 feet and then on cueing from the therapist will turn around 180 degrees and come to a complete stop. The patient has to complete the pivot turn in 3 seconds or less to score a normal grade of 3. But again, since Mike is using a cane, he can only go as high as a 2. Item 6 is step over an obstacle, and 2 obstacles has been validated for multiple sclerosis and the Dynamic Gait Index. So we're watching for the patient's ability to safely clear each obstacle without catching the obstacle, and then not to have any loss of balance. And we see the second obstacle was much more challenging. That would result in a score of 0. The 7th item on the DGI is now to walk around the obstacles in a figure 8 type pattern. So we're looking at the patient's ability to negotiate, if you will, obstacles placed in the floor and to make a turn around each of the obstacles. So he's easily able to negotiate the first obstacle, turns completely around the second obstacle, and able to walk back towards the starting position. So if he didn't have the cane, he could have been scored a 3, no loss of balance. The last item on the DGI is ascending and descending 4 stairs, and the patient is cued to do it as they would do at home, no further cueing. In Mike's situation, the first thing he does when he goes up his stairs is he does a little squat in order to stretch out those spastic muscles. So because that's his normal routine at home, he's allowed to do that before he starts to ascend the stairs. As he goes up the stairs, we see him using 2 handrails. That would put him at a 2 for scoring. No handrails would be a 3. He is able to use a reciprocal gait pattern ascending and reciprocal gait pattern descending the stairs. So for stair climbing on the DGI, he would be scored a 2.
When we're treating balance dysfunction in multiple sclerosis, there are specific therapeutic approaches that we should utilize. Number 1, whenever possible, we want to retrain the system. That is, promote neuroplasticity, better communication of all of the balance systems working together. Certainly one of the early things that we should do in our treatment approach is to address core strengthening. If the patient has a weak trunk, that has to be one of the primary focuses of the therapeutic approach. And then provide somatosensory feedback as needed. It's been demonstrated that use of visual cues on stationary targets, as well as a light finger support on a stable surface, can give the brain adequate information to help in processing balance dysfunction in order for the patient to literally regain control of their balance.
Functional exercises to treat balance disorders should consist of repeated practice of the deficits that the patient displays. So if there's a problem in performing the vestibular ocular reflex, the patient has loss of fixation or dizziness, we want to practice that, and we can do it in low-level positions such as sitting or higher-level positions such as standing or ambulation. Dynamic movements can be performed using visual fixation, as well as we previously mentioned somatosensory feedback. And then variables for adaptation and habituation of the balance system include not only that hand support, but widen the base of support, put the feet further apart, keep the patient on a firm surface. To challenge the patient, then change the surface, put them on foam or carpet or a folded floor mat. We'll now look at demonstration of balance retraining exercises. The first one that we see Debbie display is standing dynamic head and eye turns using visual fixation. So as she turns her head left and right, she focuses on the targets, using a midline target as well. To make that task harder, the therapist is removing the midline target, and now she'll be asked to scan her head left and right without stopping in the middle. Notice that she also has a narrow base of support, so that's something else that we could modify if she was more challenged. And she's able to use visual fixation, move her head, and not have loss of balance. The next task that we'll challenge the patient with is head and eye turns up and down through a vertical plane. Again, we give her a midline target to begin with. If she's successful there and has no challenge to her balance, we'll remove the midline target and then ask her to repeat the same task, but now moving her head up and down without stopping in the middle. This is a little bit more challenging for Debbie, so the therapist is guarding closer. But again, she is able to do this task without any loss of balance. So when we have success on a firm surface with a narrow base of support and using visual fixation, we can then progress the patient to an uneven surface. So now we'll ask her to stand on the foam, altering the processing of her somatosensory information, and now repeat the same task, looking up, middle, and down without hand support. So the therapist is guarding up, middle, down, and there's loss of balance when on that uneven surface. So the first thing is to see if we can widen her base of support on the uneven surface. Does that give her enough assistance? So looking up, middle, and down. If widening the base of support is not enough to perform the task, then adding that somatosensory feedback of one finger can be enough to stabilize the balance system. Recall that when we looked at muscle weakness and spasticity, we spent some time talking about core stabilization. Certainly, core stabilization is as important in balance control as it is in promoting strength of the trunk musculature when the patient is challenged more by weakness and spasticity. Debbie is able to unilaterally lift each extremity and quadruped. Now we'll ask her to move into the alternate arm and leg maneuver, which we refer to as the bird dog. And notice when she does this, much more challenge to her trunk. The therapist is giving her some assistance there to maintain that particular posture. She'll try it with the opposite leg, the right leg moving into extension, the left arm coming up. She's trying to maintain that core without loss of balance. So this would obviously be a good exercise for Debbie to work on. She was able to use the unilateral quadruped position, but with alternating arm and legs was much more challenging. Now she's attempting to go from sitting on her heels up into a tall kneel posture. This is going to require activation of the gluteus maximus muscle to come up, as well as the back extensors. Notice she has some difficulty coming up into full trunk extension, wavering a bit. So this would help us to identify that core stabilization would be an exercise to work on with this individual for balance control. Even the movement of going into quadruped and coming back up into tall kneel, though she's challenged in tall kneel, would be a good way to strengthen those back extensor muscles. Therapist is cueing her to try and maintain as an erect posture as possible. But again, you see the weakness there, so definitely a good exercise for this individual to work on. So core stabilization is important for all of our patients, not just weakness and spasticity, but certainly with balance. We saw the ball lift a little bit earlier, and we can use that as well. And actually, when Debbie has to bring her arms up over her head, it enables a better lumbar lordosis, activation of those paraspinal muscles, and even tucking the buttocks in more, so she's demonstrating more stability with this dynamic movement in tall kneel than she did just displaying quadruped to tall kneel. She's making an attempt now at moving the exercise ball through a diagonal pattern, which is going to challenge the abdominal muscles and the obliques even more as she works on holding that stable trunk. And of course, we try and ask our patients to move the ball through both diagonals. We can use the resistive band as another means of strengthening the trunk musculature. This was demonstrated in Module 2 on weakness and spasticity. You can certainly vary the resistance of the band. You can vary how much the patient is asked to rotate their trunk, and even what positions you would have them perform the resistive band in. Certainly seated in this situation, unsupported sitting is a lower level of challenge to the trunk. We could ask the patient to do the same task in a tall kneeling position, which Debbie is going to demonstrate now. But instead of rotation, in tall kneeling, we'll ask her to pull the band up overhead, activating more of her back extensors, and then to pull the band down, activating her abdominal muscles. So the therapist has to guard as well as stabilize the band, but a very nice exercise working on shoulder flexors, back extensors, stabilization of the gluteus maximus, hip and pelvic region. Here's the pulling down. Cheating a little bit there. She really shouldn't be bending the trunk. She should be holding the trunk still and then just pulling down against the resistive band, strengthening those abdominal and hip and pelvic muscles. Here's the higher level of balance challenge. Now we're up into standing. So we started in sitting. We could also do the tall kneeling activity. Now we're in standing, and she's performing the same type of challenge to her trunk and balance that we saw in those other positions, lifting the ball overhead, then moving the ball through diagonal patterns, activating really all of the muscles of the trunk. Demonstrating the opposite diagonal, we want to make sure we work the trunk symmetrically, so don't just work one side, even though one side may be involved. Always have the patients do bilateral activities. And a little bit more interesting is to have the ball placed on the floor. Debbie is now being cued to have to bend, pick the ball up, lift it over her head, and then bend, place the ball back down, and getting even more muscle groups involved now in the lower extremities and the trunk and upper extremities as she does this particular task.
In this next section, Module 4, we'll discuss the use of assistive and adaptive devices in multiple sclerosis, such as canes, walkers, the need for scooters and wheelchairs, as well as a demonstration of the utilization of functional electric stimulation in patients with MS.